Hello, my name is Natasha Gray. I'm here to present to you my scholarly project focused on reducing acute care transfers utilizing the Interact Quality Improvement Program. My committee members is Dr. Amanda Flynn and Arlene Arroyo. I am a family nurse practitioner who works at a skilled nursing facility to provide on-site care for the residents. I typically see the subacute rehab patients. These are patients who are discharged from the hospital and are in need of nursing services like wound care or IV services, or they are there for subacute rehab, physical therapy, occupational, or speech therapy. Typically, SNFs, as I'll be referring to throughout this presentation, meaning skilled nursing facilities, tend to serve chronically ill, functionally deficient adults over the age of 65. However, these are also patients who do stay long term, and they are there because they cannot care for themselves in the community independently in the home, or they lack the social support for safe dwelling in the community. And the thing that's unfortunate is that as the general population has gotten sicker at younger ages with more debilitating illnesses, patients are requiring more frequent in-hospital care at the hospital. And hospitals have trended towards shorter lengths of stay. So now hospitals are discharging higher acuity patients into post-acute care facilities at higher rates. This has led to the focus of care being shifted towards the more medically complex, higher acuity, shorter term patient. Hospitalizations, especially when they're preventable or avoidable, are very harmful to the patient because of potential medical errors. There's also increases for increased chances of frailty, meaning as the patient goes in and out the hospital, they become more debilitated, and mortality. Hospitalized older adults are at increased risk for adverse drug effects, nosocomial infections, delirium, and falls. They cause psychological stress not only on the patient but their loved ones every time the patient's going in and out of the hospital. Rehospitalizations are very costly to America's healthcare system. In 2011, Medicare spent $14.3 billion in 30-day hospital readmissions, and Medicare patients discharged to a SNF have a 25% likelihood of readmission within 30 days. One study even cited that 1/3 of readmissions from post-acute care facilities may occur within the first week. So what is the PICO? My problem is a high avoidable hospital readmission rate at a suburban subacute rehab facility. The intervention is re-educating the nurses about utilizing and using the interventions to reduce acute care transfers, or the Interact program. This program is already embedded in their electronic software and just not being utilized. Currently, there's no consistent use of a standardized approach to managing acute changes in patient medical conditions or communication format. And the outcome is hopefully a reduction in 30-day hospital readmissions. What is the purpose? My goal is that by retraining and telling the nurses about this program, is that I really can hopefully increase the visits by the nurse practitioner. That's what we're there for, to address these subtle changes in the patient before it warrants hospitalization. And when I say acute care transfers, I'm talking about hospital readmissions within 30 days and emergency room visits. Hospitalizations from SNFs are often preventable and unnecessary. And when I'm talking about avoidable hospitalizations, I'm talking about the patient was rehospitalized for a condition that, if identified early and interventions were put in place, it could have been managed safely at the SNF. And in the literature, there were many factors that contributed to hospital rehospitalizations. One was failure to recognize changes in resident status. Another was lack of communication between staff, residents, families, and providers. One study noted that in a review of 200 discharges from SNFs, 67% was rated as potentially preventable. There were 5 conditions identified in many studies that were the diagnosis attributed to that acute care transfer: congestive heart failure, respiratory disease, and I'm talking about a COPD exacerbation or pneumonia, sepsis, UTI, or electrolyte imbalance. When I talk about a UTI, think about it. Something as simple as a urinalysis with a culture, that patient could have been treated with oral antibiotics or even IV antibiotics, which is fully something capable of the SNF to do. And one study, these 5 conditions accounted for 78% of all 30-day hospital readmissions. Why Interact? Interact was chosen because in one systematic review, it was one of the most cited programs that was used to reduce 30-day readmissions. And in many studies in my literature review, if it wasn't Interact, one of the components, whether it was a communication tool or a intervention aimed at improving early recognition, was used in the intervention. Interact is also not only a quality improvement program, but it's a practice improvement project. It enhances the nurses' clinical assessment skills, and it has decision support tools like change of condition file cards and care paths. The file cards go through the ABCs of signs and symptoms. The care paths go through algorithms of common conditions like CHF, and it gives them signs and symptoms to look for. Was there an increase in edema? Was there changes in weight? Was there crackles on lung sounds? And then it gives them ideas of what they could suggest to the provider, such as different labs and what other interventions they can put in place at the facility. There's also Stop and Watch, which is an acronym that the CNAs or certified nursing assistants and the nurses could use in their day-to-day interactions with patients. There's the SBAR, which is the Situation Background Assessment and Recommendation Tool, which is a communication tool to improve the nurses' communication when they're talking about these changes in the patient status. Why is this so significant to healthcare? Active implementation of the Interact program has been associated with up to a 24% reduction in all-cause hospitalizations of nursing home residents over 6 months. A reduction of this magnitude could result in over $100,000 in Medicare savings annually in each nursing home that could effectively implement and sustain the program. Why does Medicare matter so much? Because Medicare is responsible for the hospital stay in the first 20 days of SNF admission. Also, Medicare was the highest spender in 30-day readmissions. This money could be allocated to other programs for Medicare beneficiaries. Why is this so important to nurses? Nurses are well positioned to make a change in healthcare on smaller levels within SNFs. On a statewide and national level, decreasing return to hospital rates reduces healthcare expenditures, freeing up monetary resources that could be allocated to other areas that nurses are greatly involved in, like schools and other public health initiatives. Why is this so important to nurse practitioners or advanced practice nursing? One of ANA's provisions is that nurses, no matter the role or setting, are supposed to advance the profession through research and scholarly inquiry. In the implementation of Interact is also advocacy. We notice that this is a problem and it's advocating for a population or a sector of our adult population that's often institutionalized and frail. Advanced practice nurses can enhance patient outcomes. In one systematic review, the authors concluded lower rates of depression, pressure ulcers, restraint use, and urinary incontinence in long-term care settings with an advanced practice nurse. Patients and family members expressed greater satisfaction and care when a nurse practitioner was involved. So for this project, I have the support of the Director of Nursing. And why? Because in July of 2021, the 30-day hospital readmission rate was 27.5% compared to the state average of 23.1%. And it had been averaging on the higher end for months. And again, as I stated, SNFs are now being penalized for high rates of 30-day readmissions. Why is this so beneficial to practice? This program empowers the bedside nurse. It gives them tools that they can use, like the SBAR, the Stop and Watch, decision support tools. And when a nurse is working in these type of settings where they are limited by access to physicians and the patients have complex needs, there's limited resources, the nurses must be creative, they must be critical thinkers, and they must be resourceful. When I did a literature review, there were common themes that emerged, and these were the first 4 most common themes: a communication breakdown, failure to identify acute changes in patient status, challenges in SNF culture, processes, and then poor collaboration between care professionals. The body of evidence really does support Interact. There were many studies, and they were on the higher end on the level of evidence, on the hierarchy of um, research. There were systematic reviews. There was a randomized controlled trial. The study designs were strong. They had good sampling techniques, and the data analysis, they used the appropriate statistical tests when they analyzed their data. Some of the weaknesses range from recruitment methods. It wasn't clear on how the samples were recruited, and then the generalizability of their findings because some studies use single sites. For this study and for this project, the theoretical framework was the knowledge to action. It's a planned change theory creating change on a system level within an organization. Look at the center. If you look at this upside down triangle, there's knowledge inquiry, knowledge synthesis, and knowledge tools and products. The founders of Interact already did that for us. And so we identified a problem and we tried to tailor it to the context of the SNF, and then I did assess for barriers to the Interact use before I even implemented the program and re-in-service. I spoke with the nurses about what were the barriers to the Interact use, and then through this research project, I monitored the use and I evaluated outcomes. For the methodology, so I use a retrospective chart review. The patients were mostly over the age of 65 and 95% were Caucasian or identify as Caucasian. There were 72 charts reviewed in total. 46 for the pre-implementation time frame. So from May 1st to August 31st, that was 46 charts before I did the educational intervention to look at my data, and then 26 were the post-implementation time frame, September 1st to November 30th of 2021. To be included in the chart review, the chart had to have a documented ED visit or inpatient readmission, and they had to be at the SNF for subacute rehab. I looked at yes/no questions. So the first three was if the patient was rehospitalized within 30 days, yes or no. And if the patient was not rehospitalized, were they sent to the emergency room within 30 days? So it was two different things. And then for each encounter I looked at was Interact used, yes or no. A z-test of proportions was used for this data analysis. Then I looked at the main diagnosis upon acute transfer. Was it one of the 5 potentially diagnoses, such as COPD, UTI, sepsis, or was it other? And then I used descriptive statistics frequency to look at what it was to analyze this data. And then I looked at the number of visits from the nurse practitioner pre and post re-in-servicing. And I used the Mann-Whitney U. And the Mann-Whitney U was used because the data failed a normality test. It did not follow the assumptions for an independent t-test, and therefore the non-parametric equivalent had to be used. All data management and statistical analysis was completed using SPSS. This is my resources and budget. The director of nursing, the assistant director of nursing, and myself were involved in this project. The projected cost was $772, more or less. The project timeline was about 9 months. The first 6 months was used to do my data collection, and then the last 3 months was finalizing a report and the scholarly chair approval. This project did go a formal ethics review. All potential conflicts of interest were addressed. And then after I got IRB approval, I did implement the project. There were no foreseeable physical, psychological, socioeconomic, or legal risk. No participants were engaged, and all potential patient identifiers were removed. The only possible risk was the breach of confidentiality. However, I had my own password to access the EMRs, and then any data that was collected was on an Excel sheet that was in a locked file cabinet in a locked office. To ensure protocol fidelity, it was just myself. I used the same procedure throughout the educational process. I used a in-service script, and I in-serviced each nurse individually. And then I did, to ensure quality and adequacy, each chart was independently screened. The data was entered into an Excel worksheet and checked for accuracy and completeness multiple times. I checked for any transcription errors, and then The data was reviewed by a statistician in my scholarly chair. I did meet with a statistician to make sure the appropriate statistical tests were used for data analysis. The results: there was no statistically significant reduction in 30-day readmissions, or there was no change in Interact use post-educational intervention. There was a difference in the number of ED visits. Amanda Winnie Yu indicated that there was no statistically significant change in the number of visits from the nurse practitioner post-Interact in-servicing. If you look at these two frequency charts, the first chart, look at number 6. 71.7% of the visits for the patient being transferred back to the hospital or an ED visit was because of other. Look at the post-implementation. 69.2% was other. So then that leads one to think, were these transfers actually avoidable? Could it have been prevented? And only way to really know is if you really do a root cause analysis to look at the processes that were done before the transfer and looking at the patient's overall medical condition. And then, like I said, there are some conditions that warrant automatic hospitalization. And if you look here, again, they were other. So although there was no statistically significant changes in the measurable outcomes, there's still possible changes in the nurse's thinking process with the newly gained knowledge and accessibility to clinical support tools. This project also allows for management to identify areas for improvement. So facilitates this project's success. It was in a well-established senior living community in an affluent suburb, so there was no lack of monetary resources, and the Interact program is already embedded in the EMR, just underutilized. And when I spoke with the nurses about why they weren't using it, part of it was that they did not know about the program, they were never in-serviced on the program, they didn't know about the program's importance, they didn't know about the tools, so just in-servicing them about it I was hoping would be really helpful. Barriers to the project's success. Barriers to the project's success. One of the biggest things was COVID-19. Unfortunately, COVID-19 really impacted nursing homes across the nation. Patients were disproportionately infected, warranting hospitalization because of respiratory distress or COVID's impact on their overall medical conditions. There were staffing challenges following vaccination mandates. The federal government mandated vaccination amongst the nurses, and this changed the ratio of nurse to patient from 1 to 10 to 1 to 20, as nurses had to either quit their jobs or being placed on leave. There was lack of management support prioritizing this quality improvement project amongst other competing priorities. Another issue was the use of the on-site NPs. Some physicians did not allow the nurse practitioner to collaborate in the patient's care. And then there was the inability to modify the Interact quality improvement program because of copyright issues. So when I really think about this project, I think I could have really succeeded if I had included buy-in from the physicians, because it's really at the physician's discretion if they want to send the patient to the hospital. So just telling them about the program and my project and really getting them their buy-in. I did try to reach out to the medical director to get her buy-in about this project. I think involving the families and having goals of care discussions and advanced directive discussions and incorporating more tools could have made the project more successful. Variable clinical situations do automatically warrant hospitalization, like a GI bleed. They need to be seen by different specialists. Different tests need to be done that the SNF is not equipped for. The study did have a small sample size, which increases the likelihood of a type 2 error. But I do want to state this quote. Even though we cannot control for all the factors that attribute to a patient outcome, we can control the process. A good process only increases the likelihood of good outcomes, but it does not guarantee them. I think another issue was changes in the facility census and the patients admitted to skilled nursing. So again, I did focus on a subset of the skilled rehab patients because this is the patients that I really want to focus on. There weren't many studies that focused on the subacute rehab patients. A lot of the studies were on the long-term care patients. And like I had previously stated, 25% of patients discharged from a hospital to a SNF have a chance of readmission. And then there was a limit on the post-implementation timeframe limiting the data collection. This research project was part of a scholarly project for a DNP program, and there was already established timeframes for data collection. And then I think attrition really did impact my study. There were higher rates of interact use for the first couple of weeks after I did the in-service, and then it slowly waned. Some of the limitations to this study. It was limited to one SNF and limited to a subset of residents. The NP on-site could not get involved in all the cases. There were time constraints. The study's design is retrospective, which already has its limitations in the study design. And then generalizability of these findings is very limited because dynamics from SNF to SNF vary. Some SNFs have more money resources, some have less. Some SNFs have very great leadership involvement, and we know that leadership changes the culture. And so if we had more leadership involvement, I think that we really could get buy-in from the nurses. And I think a champion is someone that is trained on this Interact program, and they are there to help the nurses for any type of barriers to use, and then just really getting the nurses engaged. Prior studies found significant reductions in hospital readmission using multifaceted interventions. So they either had medical directors who were specialized in geriatrics, they had case coordinators who worked with the hospitals during care transitions, and not only did they have the Interact program, but they might have had a nurse practitioner embedded in the SNF full-time. I think for future practice, performing root cause analyses, really looking at the processes that led to these hospitalizations and process improvement. I think there needs to be better screening for appropriateness. Before the patient is even discharged from the hospital, first, are they safe for discharge? Are they medically stable? And then looking at, does the SNF have the appropriate resources to manage that patient and their comorbid conditions? I think there needs to be joint accountability and collaboration between hospital SNFs for future readmission reduction efforts. For future research, I do wonder if the combination of the effects of pre-screening for appropriateness and developing a tool for this, and then a transition care model, a full-time NP embedded in the SNF, Interact, would this really change readmission rates? And then I wonder, there needs to be more studies that investigate the impact of acute care transfers on patient outcomes and care costs. In conclusion, the more engagement and Interact use, the significantly more reductions in all-cause hospitalizations. This was found in the literature. However, in this study, engagement did not change. As I stated, the man-Whitney use showed that there was no changes in the nurse practitioner visits, and there was no changes according to the z-test proportions of Interact use. Therefore, there was no statistically significant reduction in acute care transfers. And from this study, we learned that even having an NP on site does not mean that they are necessarily utilized effectively. My recommendation: to improve the quality of care of SNF residents, these issues need to be addressed. There needs to be earlier detection of signs and symptoms and appropriate interventions put in place. There needs to be improved communication between nurse to nurse when they do their change of shift report. There also needs to be improved communication between providers and nurses about the change in patient condition. The nurses really need to emphasize, hey, instead of just saying this patient doesn't look right, give more details. This patient had a weight gain of 3 pounds in the last 24 hours. And when I did my exam, there were changes in their lung exam. There was changes in the patient's intake and output. There needs to be increases in the available resources to manage the situation safely and timely at the SNF. Instead of the federal government penalizing SNFs, they need to use more monetary resource to give the nurses and these SNFs more resources. There needs to be more communication between patients and families and the physicians about the goals of care. Is the SNF appropriate? Does this patient qualify for hospice? Does palliative care need to be involved? And more importantly, SNF leadership needs to be more motivated to reduce acute care transfers. This project, the outcomes were shared with the Director of Nursing at the SNF, and this final project will be disseminated among fellow Maryville students, and an oral presentation will be shared amongst the students. Any questions, please contact me. This is my email. And I thank you again for taking the time to listen to my project. I really hope you learned something. Please take care.